We just spent 45 minutes discussing the evolution of the healthcare professional-patient relationship. Very interesting dynamic in the room that I was in, very different from the previous session. I wonder if you found the same. Less consensus, possibly. So I look forward to hearing what Group 1 came up with. So who is reporting back on Group 1?
Is that this group?
Yeah.
I'd be happy to.
Okay, go for it, please.
So we had a great artist here, Allison, who did this drawing, which is visualizing all of the different subjects that we talked about.
I'm conscious of the fact that's really small, so you're going to talk through that.
So yes, so I'll talk through it. So we have here a patient and a clinician, and we discussed about the fact of how important it is for the patient to prepare, to differentiate amongst the kinds of patients because some are empowered and some are not, that there's a before, a during, and after of the 10 minutes, and that today we have to be very much aware of the fact that the one consultation, given how diseases have become chronic, is only a small piece of the whole picture, which is why we have this here at 10 minutes versus life. We discussed the fact that even though things are changing, and in particular in medical schools today, they are changing, that there's still an impact of the strong hierarchical nature of the healthcare professionals, and we mentioned that there is evidence that while teamwork is required in surgery, in births, in many situations, that this full teamwork, maybe the exception of Switzerland, is not always achieved. I was just mentioning that Sia had an excellent experience of the teamwork in the birth of her child, but he said that there's evidence that, and even studies demonstrating that the lack of teamwork is creating greater surgical problems. The role of nurses was highlighted as well, the fact that not only are there in certain countries insufficient physicians, there are insufficient nurses. And the nurse reference was within the framework of a greater question of shouldn't we be rethinking what healthcare professionals' roles are in this world where information is more accessible and other people than the physician could be accompanying the patient through this information highway to the extent that they would want that. All of this has to be taken within the context of which healthcare system. I know that other groups have mentioned the concierge system for treating, where a patient pays a certain fee to have better access, and certainly things are different in the UK from France, that things are different in the veterans. In the US, things would be way different in a country like Tanzania, where you might not get to see a physician at all, and where life expectancy is 46. It was pointed out that the issue of the physician-patient relationship, it's never been ideal, and so that this is not new, but I do think that the opportunity to find other physicians, to find other information is changing what goes on, the dynamic that goes on in the room. It was pointed out in an optimistic way that there's a lot of to be gained from the nuggets of good research. There's research being done here and there of what are good new practices, but we're not aware of anybody who is saying, I'm going to take all of that research of better practice and apply it to my system. And maybe the reason for that, as was pointed out by somebody, that this is considered soft. That this isn't hard science, like how do we cure malaria? These issues of personal relations, except for maybe the psychiatrists, are soft issues, and until they're taken more seriously, and the benefit of them is taken more seriously, they're not going to impact the systems because they're working with emergencies. Do we have enough people staffing the emergency room? Do we have enough people to receive the patients? And they're not taking the time to rethink this whole physician-patient relationship that certainly is the basis of all of medicine. Where would physicians be without patients? Could be a good way to start the rethink, and I guess that's why this subject was chosen. And that was my last sentence.
Fantastic. May I ask the representative from room 2 to step up and give us our insights?
too.
Yeah, that's good.
Go on your
Yeah. As you can see, one thing our group was slightly lacking in is artistic talent to come forward. So
it looks impressive.
it looks impressive. Yeah. We managed to capture the starting point of our conversation very well, but not the middle or the end. So to kick us off, we started off by very much thinking around in a way, the continuum of engagement. So ideally, you have a fully engaged doctor or fully activated clinician, and a fully engaged patient, fully activated patient, coming together to come together in this wonderful, fantastic sort of patient-doctor relationship where they're mutually exploring issues, care planning, setting goals together, monitoring them, bringing it all together, and everyone's happy and fulfilled. Well, we quickly recognise that, of course, and then we start saying, well, surely then patients and doctors are on different levels on this. They say, well, no, this is a matrix. This is much more complex than this. This is not a linear process from A to B, as it were, where you sort of, improving this and improving that. It is much more complex than that. Then what else did we talk about? Yeah. And we talked a little bit about identity as well, the identity of the patient, the identity of the clinician, and how identity in play has a role too. And what else did we talk about?
So we talked about, we tried to come up with an analogy of what this relationship was like. So we started talking about a tango. So, when you're going in one direction, the physician is in charge of the relationship. You're coming back in the other direction, maybe the patient's in charge of the relationship. But the reality is, we wound up with saying, no, we're looking for the right dance partners to be able to find each other. So at the end, we figured it was more like online dating.
Well, online dating, but also those partners will change as well. So, and we also talked a bit about the expectation being put on sort of the healthcare professional here to be the clinician, do the diagnosis, do the treatment, be your social worker, be your caregiver, etc., etc., etc. So we're talking very much, also around how this needs to be opened up and how there might be elements which are dealt with, which are very personal, which are very much with the patient-clinician relationship, which don't want to be opened up, but particularly around health behaviour change. As we move from the who is doing this and what needs to happen to that, how does this happen? So how do I lose weight? How do I get support to change my behaviour?
And why?
And why as well, and how those different elements then come together. And this is much wider than a healthcare professional. This could be a whole range of other individuals as well, from sort of the expert patient in inverted commas through to sort of online support groups, to a whole range of other activities.
And communications tools.
And communication tools and decision-making tools. When someone said time, and we don't just started. Was that a reasonable summary?
Yeah, that was the non-consensus that we reached.
Yeah. So all those who were outside of that consensus will now need to give their version of events, which in a way reflects a doctor-patient consultation, doesn't it?
Yes, it does.
Both go up quite often with two quite different versions of events. It's only in subsequent interactions that those two interpretations begin to come together. Because I, as a patient, get one thing, you as a clinician think have told me something, but we've both come away with different.
And we said, how do you judge successful relationships? So what's a successful relationship? How do you measure that? Is it just simply the healthcare professional saying, I saw enough patients in my surgery this week? Or is there some performance measure that, your patients did better, understood their disease, had better outcomes, etc.? So how do you judge a good relationship?
Yeah. So we were talking around actually moving, looking at the performance of clinicians on their ability to support and increase patient activation within the patient population.
So just thought, on the basis of what you just said, could it be better for a GP to see 20 patients but end those consultations with and I will be online for between the hours of 6 and 8 tonight or whatever if you have a question, and then or even phone them up, or communicate with them, or whatever, write an email, or whatever it might be, with those 20, as opposed to seeing 40 and them all going away with it?
No, I would be inclined personally to see it more as seeing those 40, coming up with clear decisions about the way forward,
First time.
and then signposting them to a trusted community where they can get the support and information to take those agreed actions forward, which the GP or the clinician or the key clinician might be part of that community, but there will be a whole number of others. It's a bit like bringing up a child, right, often, isn't it? You need aunts, uncles, grandparents and everything, all working in different ways. And for many, when you're first diagnosed, you want quite a paternal relationship. You want someone telling you what to do, reassuring you, saying, hey, don't worry, we'll deal with this all time in. But as you gain your confidence and your skill base, that relationship changes and becomes one of a partnership.
Well, we talked about that.
You grow up with the patient, don't you?
Right. And you talk about, sort of the time points. If you have your diagnosis at your first intervention and then you're not touched again until the next time you go back, the likelihood of successful management is lower than if there's opportunity for the community of practice to have some influence during that timeline so that you're more compliant, more understanding, your questions are answered, so that by the time you go back, you were prepared going in and you were reinforced before your next visit. So the answer is absolutely.
So maybe we need to start thinking around sort of the patient-clinician relationship, of the patient-clinician support community relationship, and actually begin to open that up to partnerships or the sentences.
There's a question in the stream about what constitutes a good, thank you very much, Jim, a good healthcare professional-patient relationship. And we did touch on this, and just very quickly, I don't think we quite teased out why we thought this was the case. We thought you could define an effective healthcare professional-patient relationship by attempting to shorten the distance between an effective patient and an effective healthcare professional. So what that throws you back on a further definition. What do we think an effective patient was? Well, we felt an effective patient was a patient that wanted to care for themselves, that had access to care and resources, which is of course critical, that knew how to care for themselves, and actually was capable of bringing those elements together and making it happen. From a healthcare professional side, we thought an effective healthcare professional was managing patients, not just diseases, not just seeing diseases on legs coming through the door, was able to deliver an effective diagnosis within the context of shared decision making, and was able to activate that patient focus on self-management. So that's what we felt those meshed together.
We had a discussion on that as well, and we talked about the relationship has an outcome, have the best care, and the best care can depend a lot on what the patient does not need to have to be the standard of care in terms of treatment. So
the best care doesn't have to be the standard of care for treatment, but
one example that Alison was giving was this young MS patient that was on disease-modifying agents, but wanted to have children in the future, so she was taking off that treatment to enable her to achieve something that for her had a high priority and gave her the best care. You have that a lot in cancer patients, end-of-life care. You go for another round of chemotherapy that extends your life over a couple of months, that reduces your quality of life, and you enjoy a shorter life with a higher quality. And those are decisions that need to be taken together in that relationship. And I think this is where we see the relationship evolve as well, as before those things weren't discussed, but just sort of we got the standard of care because that was the best care. Now that definition of what is the best care for an individual has evolved.
So within the context of what defines an effective healthcare professional-patient relationship, that would be making sure that the patient has access to knowledge about all the options available to them and expresses them openly and transparently and frankly with their healthcare team.
Sometimes it's sometimes it's